A lot of women's health conditions is, are we doing the right timing? So obviously the menstrual cycle adds another layer of complexity. So there is timing. So when should we be delivering these treatments? And this is for assisted reproductive technology as well. There's obviously different stages. There's the down regulation, there is these trigger injections, there is things like that. So when do we deliver the treatment? When is the best time? Because obviously the body is in different phases. It's doing different things at these times. Same for menstrual pain, for example. Do we deliver the acupuncture once a week? Do we deliver it 3 or 4 times in the week before the period? What's better? And often, and sorry, that's just the reading on dose, and Sandro's very kindly already added that, and also the interview, which I would highly recommend watching. And so one of the other things that complicates this, not just with IVF, but with acupuncture research in general, is different cultural expectations of frequency of treatment. It's really important to point this out because it doesn't matter just what the research says. And the reason I say that, and it sounds strange for a researcher, is it doesn't just matter what the systematic reviews and meta-analyses say. It also matters what's practical. And the reason I say that, so as part of my PhD, I looked at delivering acupuncture for primary dysmenorrhea. And we did some focus groups with practitioners in New Zealand, Australia, and those who trained in China, and then we're now living in Australia and New Zealand. And we also did focus groups with women. And what we found was that, yes, in China, daily treatment or almost daily treatment is very common. And you'll often see this if you read the research out of China. They'll be treated for 5 days. They'll have 2 days off. They'll be treated for 5 days. And this might go on for several months. The problem with this is it doesn't necessarily translate to a Western context. So that's something to really, it's not that we shouldn't be doing it, but it is important to keep as a consideration is how might we be able to deliver a higher dose while still making it practical, both for people in clinic, because I'm sure many of you might be in clinic by yourself. You might have a clinic with maybe 1 or 2 beds or 1 or 2 rooms. If you needed to treat someone every day, you'd probably find that was quite problematic. You wouldn't be able to see many people. And also cost, people find it expensive. They also might find the time constraints are very difficult. So this is what our research found is people said they'd love to come for acupuncture more often, but especially women tended to put their health lower on the list. So they would look after their children or their husband or their family, and they would then tend to, at the end, they would be like, okay, I can probably afford to spend an hour a week. Might not be such an issue with IVF, but just important to say. So anyway, let's talk about our most recent systematic review. So that's obviously not me, that's Caroline, who is the lead author. And we published this in Reproductive Biomedicine Online just over a year ago in January 2019. This was the first systematic review to include Caroline's very large acupuncture and IVF study. And that study was acupuncture versus sham. And you might be aware that it found no difference in the outcomes between acupuncture and sham acupuncture for IVF. It delivered 3 treatments, 2 on the day of embryo transfer, so pre and post, and 1 between day 4 and 9 of the stimulation phase. So we're interested because this protocol for her trial was developed way back in, I think, 2010. And there was been a lot more thought around dose. So we were like, okay, let's look at some of these reasons why we might be finding these conflicting explanations. So let's look at the data, and we split it into subgroups. So that's what I talked about before, subgroup analysis. So the aim of our study was to review the clinical efficacy, effectiveness, and safety. So just a brief explanation, efficacy is usually when you're comparing something versus a placebo. Effectiveness is when you're comparing it against some kind of active treatment, so usual care or something else active. And obviously safety, because as I said, safety should always be reported in systematic reviews. And this is our question, which is the most important. Remember, all the way back on the early slides, what's the review question? And so we're interested in acupuncture as an adjunct to embryo transfer to improve reproductive outcomes compared to controls or to no adjuvant treatment. So another fancy way of saying they didn't get anything. And we're interested in improving clinical pregnancies and live births among women undergoing IVF. So the reason this was important is that we're looking at it as an adjunct to embryo transfer in women undergoing IVF. So that's what our study looked at. We didn't look at it when it was delivered not on the day of embryo transfer. We didn't look at it if it was delivered not in conjunction with assisted reproductive technology. So this is our study is only looking at this. Our primary outcome was clinical pregnancy. Secondary outcomes were live birth, ongoing pregnancy, miscarriage, and adverse events. Why did we choose clinical pregnancy? Because that had the most data. Most of the studies reported clinical pregnancy rates, much fewer reported live birth. So it was going to give us the most important, the most information. But obviously live birth rate is actually the outcome that most people are looking at or wanting. So just a quick set of definitions. Clinical pregnancy is an ultrasound showing a heartbeat, and it's usually at about 8 weeks. Ongoing pregnancy is pregnancy continuing after 12 weeks. And live birth, hopefully, is self-explanatory. That's a live baby being given birth, whether it's by cesarean section, vaginally, whatever. Ongoing pregnancy rates were reported by some, but not all. And obviously miscarriage and adverse events. So adverse events were things like bleeding, fainting, anything like that. Okay, so this is what we included. And again, like I mentioned earlier, this is the most important thing to read first in a systematic review. What were our inclusion-exclusion criteria? Because it will explain what we did and what we're looking at. So anything that compared acupuncture with sham or no treatment. That treatments, like I said, had to be administered within 1 day of embryo transfer and with the objective of improving conception and IVF success rates. So to be in our study, they had to have delivered a treatment within 1 day of embryo transfer, and their stated objective had to be around IVF success. They could be undergoing ICSI or IVF, and the intervention had to involve some kind of needling based on traditional Chinese medicine theory. So we only included those where they stated, or we could deduce that they were doing TCM, had to be manual or electroacupuncture, and it had to be on the body. So if they just use ear acupuncture, they weren't included in our study. And reporting had to include one of these outcomes. So obviously if they reported on it for IVF but didn't report on pregnancy rates, we didn't use them because it wasn't part of our study. Excluded, really important, trials administered at other stages. So if they didn't do one around embryo transfer, we didn't include it. Non-randomized studies, we didn't include. Crossover trials, we didn't include. Dry needling, so myofascial trigger point needling, didn't include. We didn't use laser, and we didn't include TENS either. So we did find 20 trials that met the inclusion criteria, and they range from pretty small, 46, up to 848, which was Caroline's study. Studies between 2002 and 2018. And like I mentioned earlier, it's really important to collect these kind of study information. So where did they come from? What did they report on? So as you can see, 20 trials reported on clinical pregnancy, and that was one of the reasons why we chose that as our primary outcome, to get the most data that we could. 14 trials reported on live births. And they were from all over the world. 4 studies from the States, some in Italy, some in Germany. Interestingly, very few studies from China, considering it's an acupuncture intervention, only 2. And most of the trials did, I guess, what many of you will be familiar as the technique that Paulus studied, kind of made famous in the early 2000s. 2 treatments, one before, one immediately after embryo transfer, within a couple of hours. And then 5 trials, some added some kind of extra. So they either did a treatment during the pre-phase, so ovarian stimulation, so before the embryo transfer, or they did them, 3 did them in the luteal phase after the embryo transfer. And 7 of the 20 trials used the standardized Paulus acupuncture protocol. The others used a modification. So what did we find? No statistical difference between acupuncture and sham control for any of our outcomes. And I think I've got a, don't have the forest plot on there for the main outcomes, but we basically found that there was no difference. So acupuncture, sham, for all of these trials, there was no difference in clinical pregnancy, ongoing pregnancy, live birth, or miscarriage. However, there was a statistically significant increase in pregnancies when acupuncture was compared with no treatment. And that was, I believe, around 34%. Sorry, let me just pull up my, 32%. So let's briefly just talk about this. So in systematic reviews, outcomes will be reported usually in one of 2 ways: odds ratios, which will be reported as OR, and risk ratios, or relative risk, which will be reported as RR. They're not the same thing. So relative risk, I find, is more intuitive. So if you have a relative risk of 1, it means there is no difference.